Every aspiration we have discussed over these 2 days, be it universal health coverage, resilient supply chains, a trained and competent workforce, digital transformation, all of these, they carry a price tag. And in low and middle income countries where fiscal space is constrained and competing priorities are real, the question of health financing is, in fact, existential. But here is a critical question that our next session poses. What if technology, artificial intelligence, digital health platforms, and digital public infrastructure in particular could make every buck in the health system work harder and better? This session brings together finance minds, technologists, insurance leaders, and public administrators to ask, how do we deploy AI and digital health not just as clinical tools, but as instruments of financial efficiency, equity, and sustainability? Moderating this session and bringing 24 years of experience in research and training in medicine procurement, pricing, healthcare financing, and health systems is our Global Director for Health Systems Research and Policy at Access Health, Mr. Maulik Chokshi. I now hand it over to Maulik to take the session forward.
Thank you very much, Stuti, and it's a pleasure to be here. Um, as Stuti kind of alluded to it, health financing, and if you go to health policy discourse, I think so. There are various frameworks which assesses how health system performs and how it could be assessed. Assessed in terms of measuring its responsiveness, its financial risk protection, and its ability to create health outcomes, better health outcomes. And when we start talking about this health system outcomes, I think so. There are also some pivotal or non-negotiable input components that are required for health system to work optimally. And one of the most important levers of that is financing, money, right? If you need to buy medicines, you need money. If you need to have human resources, you need money. If you need to train human resources, you need money. If you want to create digital ecosystem, you need money. So money is one control knob. If I go to Robert Noyce control knob theory, it's one control knob which has a potential to change behavior of supply side. And here when I say supply side is hospital, doctors, providers, supply side payers, and it has got potential to also change demand side functions, how consumer behave, right? So if you want to increase uptake of a particular health commodity, or if you want a particular health program, you can incentivize demand side financing, your demand side people to enhance access to healthcare. And in Indian ecosystem, Janani Suraksha Yojana is a classical example through which we kind of enhance institutional delivery and resulting into decrease in MMRs and IMRs. So financing lever is a very strong control knob which can really affect the outcomes of your health system. Now, we had COVID, right? COVID changed the need, COVID changed the way things happened, and it was not enough. We had a global health financing crisis to one of the biggest contributor in global health financing space changing its priorities, changing the way it wanted to allocate money, and most of the around 60% of global financing is dried out. So as of today, and now we have got crisis going on in Middle East, where again it is kind of using up all finances which are available at the state level. When I say state, or country level. So in this situation, to demand states, state again government, to increase financial allocation is a very, very difficult task because there are competing priorities. Not saying that this priority is good above other, but there are competing priorities. And at that context, raising additional revenue for healthcare is not an easy task. But there is always an opportunity to use whatever money that we have efficiently. So let's say if government of India is spending 135 crores on healthcare, there is enough opportunity to make sure that each and every penny that is spent out of 135 crore has got its valuation to it. And that's value for money, right? In yesterday's session of strategic purchasing value for money, we talked about strategic purchasing as a lever, one of the lever of enhancing efficiency of health system. But in recent time, one of the efficiency in kind of pathway that's coming is artificial intelligence. Can we use AI to make health systems or health financing decision to make efficiency gains which are difficult to attain? And that's what the session is trying to focus on, how artificial intelligence in digital health ecosystem or digital space can help in increasing efficiency of the revenue that you have already available to us. Now, to have this conversation, I would like to introduce panel first, and then we'll go for a 15 minutes presentation by our speaker NK Mauer from WHO Geneva. So NK has been she'll be making a 15 minutes presentation, primarily focusing on how digital health and AI ecosystem are evolving globally and how it is helping in kind of strengthening the health system overall. So that's what NK would be focusing. And then we have got a fantastic panelist in form of Ajit sir. May I request Mr. Ajit Kesri, who is ex additional chief secretary of government of Madhya Pradesh. And he is not here because he was additional chief secretary of government of Madhya Pradesh, but he was the first Indian registrar for Aadhaar, one of the kind of cornerstone of our digital health ecosystem that we are talking about. He has also done innovation in GIS based planning and governance. He has also been on the board of a social stock exchange. He has also been one person who has tested e-rupee in various ecosystems, not only in health but also in agriculture. So I think so. There are a lot of kind of experience that we can harness as far as enhancing efficiency of public financing and private financing. So thank you, sir, for joining us. Then we have Dr. Manish Priyadarshi. He is the Director of Development Monitoring Evaluation Office at Niti Aayog. Sir, may I please welcome you on the stage? And he has been working with WHO, UNICEF, Gates Foundation on strengthening health system evaluation. So at Niti Aayog, we have got aspirational district and aspirational block program, which are kind of indicators which tracks how states and blocks are are evolving over a period of time. So sir brings in that experience, that what is happening at the field level and how we are monitoring the efficiency of the money that is being utilized at field level. Then may I invite Mr. Mitul Thapial, who is the managing partner at Microsoft Consulting. And Microsoft Consulting has also been involved actively working with Niti Aayog and Gates Foundation, working at a state level in creating an ecosystem where consumer voices are heard as part of strengthening the utilization of money by making consumer aware what is there to be, what is available to them and how it could be utilized appropriately. We may also be joined by Mr. Alok Ranjan. Alok was supposed to join here, but there is a Minister of Statistics meeting which has started at 11 o'clock and end at 12. He was supposed to join us at 12:15, but that meeting has been delayed by half an hour. So let's hope that if Alok can join in. But it has been pleasure to have a gentleman on the dais. But may I go to NK to start her presentation and reflect what's happening in kind of a digital health space and how AI is being looked as one of the transformative initiative to make efficient use of financing available. NK, the floor is yours. You are on mute, NK. You're still on mute.
So, hi, hello, good afternoon.
Yeah.
Can you hear me now well? Is the sound
yes,
okay?
Please.
Good.
Yes, please. Thank you. 15 minutes, thank you. Thank you.
Yep. Just a second, I'm sharing and then we can start the 15 minutes. All right. So now you should see my screen.
Yes, please.
Good. Okay, great. Well, thank you so much, Dr. Maulik, for the very nice introduction. And thank you so much, in fact, for this invitation to this panel. It's really a big pleasure and honored to be part of this. Unfortunately, I'm not here with you. I'm Inke Mattauer. I'm working in Geneva at WHO in Switzerland. So I was asked to provide a framing presentation and to give an overview of the issues as we look at leveraging digital technologies, digital transformation for health financing, and also public financial management. My perspective is really on low and middle income countries. That's the work that I've been doing. And of course, I'm fully aware that India is quite advanced in this digital transformation. But I think it can still be helpful to have this sort of broader view. So when I talk of digital technologies, this is what I'm talking about. Basically, we refer to electronic tools, systems, and devices that generate, store, process, or transmit data. And of course, you all know that, the difference between digitization and digitalization. But I think it's just very important to keep in mind that digitization basically just means that we have the same business process, but it's digital. For manual paper, it's digital. It's not really changing beyond that. But digitalization is really about the process of leveraging these different digital technologies. And so that creates actually the potential for transforming business processes. And I'll come back to that actually. Here, I just wanted to give an overview of the wide range of different types of digital technologies being used in health financing. Starting, of course, with web-based databases and platforms. I mean, that's basically just digitizing and then using more advanced tools to present the data, to organize, manage the data. But nonetheless, extremely important. Lots of examples here that I have listed. I'm not going to go through them. I've just actually put in brackets, to which health financing function they refer to. So we have the three main health financing functions: revenue raising, pooling, and purchasing. And so I've just actually outlined that. So we see that, in fact, digital technologies are being used across the whole set of health financing functions. But in fact, you will see purchasing most frequently here. And that's what we really see in practice in the field. We have mobile phone applications, we have digital payments, digital wallets, we have biometrical identification. We have machine learning, of course, with big data analytics. Again, multiple use cases that we find on the ground. And now more and more generative artificial intelligence being used. Quite interesting. I think, there's room for lots of discussion about how much and how good this is actually supporting health financing functions. So I've just put here an example. It can help with revenue forecasting of taxes or health insurance contributions. It could even be used actually to support the development of a health financing strategy. I think there are certainly some use cases, maybe not sort of officially, not formally, but of course we all use generative AI for various thinkings, suggestions. Again, the question is how good is it? What we get delivered? And last but not least, I would like to mention blockchain, which can be used for securely storing claims or patient information, whilst ensuring privacy, or of course for verifying identity and credentials to minimize fraud. Now, there are many, many more digital technologies which are not mentioned here, such as wearable and robotics, but I'm not putting them here because they're in fact not supporting health financing tasks as such. They're being used for other things. So I think this is sort of the range of digital technologies that we see being used in health financing and in public financial management. Now, here on the right-hand side in orange and yellow, and I'm quite sure you have seen this multiple times, I've put the sort of health financing for UHC framework. So here we see the UHC intermediate objectives and the UHC final goals. I'm not going through them because I think this is all known. But what I want to put our focus is on the left-hand side, which is the blue, really to show where is it that digital technologies come in. So they come in at different health financing tasks. I would not even say at the function, but at specific tasks. And so, of course, this is not exhaustive. This is just illustrative for revenue raising and the other health financing functions. You would see multiple digital tools being applied. And so if they're well designed and well implemented, then they contribute to improved intermediate object, or to the improved achievement, sorry, I should say, improved achievement of the UHC intermediate objectives, ultimately thus contributing to the UHC final goals. But it's a long sort of contribution and attribution chain, and it's not very easy actually methodological wise to really show that. But yeah, just here on the next slide, showing that PFM is underlying the free and cutting across the free health financing function. So just showing that. But what I want to come to is I want to come back to what digital technologies change. So they can change how the health financing functions and the tasks are undertaken. So they change these business processes, and we'll illustrate that in a minute. And they also change how the different health financing stakeholders, Ministry of Health, purchasing actors, regulators, etc., how they interact. And so that is what's making the difference, right? Nonetheless, at the end of the day, the UHC objectives, they remain valid. They must remain valid. So digital technologies coming in don't really change our framework on framing on that. And so if we think about the effects of digital technologies on health financing tasks, our positive scenario is that this digital technology that's applied enhances, simplifies, supports a health financing task. That's what we would want to see ideally. But, and I think this is really where we have to do a lot of evaluations and still more rigorous research to understand how really are digital technologies affecting health financing. Because in fact, we do have also evidence that the use of technology may also play out in a negative way. The application of a digital technology can negatively affect a health financing task because of various reasons. Could be inadequate design, inadequate implementation, or because it's not really adequately aligned with the digital ecosystem. So there's a lack of so the digital ecosystem itself is not sort of up to what the digital technology would require, or vice versa, there isn't alignment. So in the end, you might find that actually processes are being done both manual as well as digital, at least during a sort of transition process with lots of cost and inefficiencies. Plus, you could also, and we have seen that, you can also think of a scenario where digital technologies do enhance, in fact, simplify and support a health financing scheme, but that in itself might not be UHC oriented in the first place. And I'll give the example of private or voluntary health insurance, which of course, if it's well regulated and complementary or supplementary to publicly financed health coverage, then that's perfectly fine, but that's not always the case. And what we see is that, digital technologies are being really well used by private and voluntary health insurance schemes. And so that kind of, puts in question this general health financing principle that we have, namely to rely largely on public finance. So these are just issues that we have to be aware of. So obviously the issue is not with the digital technology itself, it's about how and for what it's being used. Right. So this is just another illustration again of how we can visualize these potential benefits of digital technologies. As I said, they unlock new processes, and I will just show an example in a second. Plus, and I think that's very important, they can enable policy options or policy instruments that would otherwise not be feasible. So for certain processes, it simply has to be digitalized. You need to have that efficiency sort of jump in order to undertake certain functions. And we know it already with claims management. Claims management still is being done manually in a lot of countries. Fortunately, we see this shift going to digital claims. But I mean, that just gives us an insight of the constraints and what would otherwise be possible. So in fact, here I want to show the example of Estonia and its digital claims system. It's some work that we did a couple of years ago, and it's quite amazing. Obviously, okay, digital claims are being digitalized, and then they're submitted in an e-channel, which of course speeds up this whole process of verifying the claim, getting the payment to the providers, having fraud detection elements in there. But I want you to look at the blue circles and the ones at the bottom of this graph. The claims digitalization also allows for many other more advanced purchasing functions, such as payment for performance, so a quality bonus payment program that Estonia uses, which is based on these digital claims that allows for enhanced performance monitoring. And what I think is really very interesting, and I haven't seen it in many countries, is that with the digital claims, there's an automatic contract setting process being triggered. So based on utilization rates, based on the services that the hospital provides, contracts between the health insurance, the purchasing agency, and the hospital are being sort of set automatically. Of course, they're being then verified and checked upon, but first of all, the process is being automated. And the same is done, and that's at the bottom there, for the monitoring of the contract execution. So both hospitals as well as the health insurance agency, they can at any time look at how far is this contract actually being implemented in terms of its volume or in terms of its budget ceiling. And last but not least, with the digital claims, it's possible to have sort of a risk prediction, a patient risk prediction for enhanced care management. So it really unlocks, additional advanced purchasing functions that wouldn't be possible at all without having digital claims. I'm just looking at the watch. Okay, I have another 5 minutes, so I'll just move forward. Now, as we think about the effects of the benefits of digital technologies as well as the risks, I think we always have to challenge ourselves and really continue exploring. Namely, do certain digital technologies imply a change of our thinking on health financing policy principles? As we know, with mobile payments, with mobile wallets, it's easier to collect direct health insurance contributions from people working in the informal economy, even though, at least in our WTO health financing policy thinking, we're saying they're so high admin costs and it's difficult to sort of establish the ability to pay. So ultimately, let's shift to general government health expenditure. But I'm asking sort of self-critically the question, if indeed with mobile payments, it's a game changer, it's changing of how you can collect contributions, direct contributions. What does this mean for our health financing policy guidance? I don't have an answer. I'm still keeping up the question there, but I think it's a very important one. It's just one example. There are many other questions here. Okay, I want to move a little bit and talk about the challenges and risks when introducing digital technologies. I don't think I have the time to go all through these points. And many, they are generic. They are not really specific to health financing, such as, of course, you need adequate design. There's the issue of digital divides. We have gaps in data security and protection. But let me shift more a bit on the right-hand side. Again, you find these risks not just in health financing, but also in the health sector. But I think for health financing, they're absolutely pertinent to look at this. So one is this lack of alignment between design and implementation with context and with the digital ecosystem, with the infrastructure, with the acceptability, with digital capacity. And so I think that's where we find a lot of constraints and then hurdles. And more important or equally important is the issue about interoperability and the lack of coordination across system components and projects. There's this fragmentitis. And you may also, have experienced that in your own country. This is an issue across so many countries. And it's not a technical issue per se. It's a governance. It's a data governance issue. It's about data sharing. But despite it being solvable from a technical point of view, this continues and is being repeated as an issue. So what does it mean? What do we need to have an effective digital transformation? I was just talking about governance. We need to have clear governance structures to drive that digital transformation in health financing, in PFM. It's equally important that digital technologies are actually being explicitly included in a national digital health strategy. Again, I can't say that I looked at 193 countries and national digital health strategies, but in the ones that I looked at, health financing and digital technologies and health financing don't really feature there sort of explicitly, but I think this is absolutely important. And also the question of how to link it to the broader digital public infrastructure in health and even beyond that. And again, we find this de-link that the development of digital technologies, this fragmented development, these multiple pilots, they are not sort of part of a strategy, and they hence do not systematically contribute to the digital public infrastructure. Okay, I have a few minutes left, and I will talk about artificial intelligence and the use of machine learning in health financing. We did a study a couple of years ago, looked at where and in which areas are digital technologies, machine learning approaches being used, and it's across all the free health financing functions for many different specific aspects. Now, this is already a couple of years ago. I think if you do this study again now in 2026, you will have an explosion, an exponential increase in papers and use cases. What we can say is obviously AI machine learning applications, they have the potential, in principle, they have the potential to affect and contribute to all intermediate and final UHC goals. Their primary benefit is, of course, higher accuracy, enhanced speed, and hence higher administrative efficiency. You might potentially argue that there are less conflicts of interests, but again, maybe a question mark around that. They help to reveal hidden patterns in data, and hence, again, it's this more accurate prediction. However, I think there are also many risks in terms of the inadequate data or inadequate quality data with bias in algorithm design. And so again, for health financing, this potential resulting in inequities or inclusion is can be quite catastrophic in the actual sense of the word for people. So that's why there is need for very careful regulation. And again, I'm bringing it back. We don't have enough evidence yet. Or let me put it the other way around. I think we still need to continue collecting evidence, have rigorous evaluations of use of digital technologies as well as AI and machine learning beyond, higher accuracy, enhanced speed, and higher administrative efficiency. What really are the benefits? I think we have that for specific use cases and examples, but overall, I would suggest that we still need to continue having better evidence. I think this is my last slide. We have to ask a couple of broader questions, and they really relate to policy. So obviously, as I was saying on AI machine learning, regulation is needed, but what regulatory provisions really? Now, just to give an example, should it be allowed to combine all kinds of data, and who should be allowed to actually combine that data? I'm not seeing in a very explicit discussion of this question, for example. Then how much digitality do we want? How much use of digital technologies do we want to sort of be faced with as patients, as health workers? Do we have this discussion, or is it just happening? Like, who is driving this? Where do we want to go as society, right? Who is driving this digital transformation? So a number of questions, and maybe this is triggering some discussions for later on. Thank you so much. I just wanted to acknowledge also my colleague Moritz Piatti-Finchkirchen from World Bank. I have used some of the slides, the blue slides, from a previous presentation that we have done in Montreux. And with that one, just to say we have a number of country case studies on low and middle income, high income countries. And we also produced some guidance on how to assess the effects of digital technologies on health financing. So with that one, I'll stop and I'll hand over to Maulik. Thank you so much.
Thank you very much, Anke. It was a clear, fast presentation within timelines. Thank you very much for that. Anke, but I still want to want a bit of clarity before I go to my other panels. You did talk about the role of digitally technologies on public finance management platforms, but they do exist, right? It's not that it's something new. A PFMS, I know India when we started a national health mission. I think so. We digitalized ourselves in 2014, 15. So it's almost a decade before. But still, there needs to be certain governance and institutional decision that needs to be made for them to really act, right? Or to show some results. So, what are those things that are really required for the transformation to be visible?
Yep. So, yeah, to make visible is sort of it's a bit of a tricky word. So I guess you really want to ask about, so what is it that we need to have effects for this transformation? And what I've seen in a lot of countries, and again, I mean, I guess you, the panel, the audience, you can then translate this for India. But in many countries, the problem is lack of interoperability and lack of data sharing, understanding which data is needed, what data to collect, and what has to go in, for example, in these data platforms. In many countries, there is not really a clear data governance framework. It's evolving for sure. I mean, I think we have to acknowledge these processes, but I don't think we're yet there. And again, it links back to this issue of digital public infrastructure. So if you ask me about a factor that's absolutely relevant, I would refer to digital public infrastructure, having a clear strategy on how to develop that and how to link then financial data, IFMIS, integrated public financial management information systems. So there's that point. But if you allow me, let me also come back to something maybe more fundamental. And we have had this discussion before in our prep talks. Digital technologies are often sort of treated as if they're the solution to all kinds of problems, but they're not. I mean, they can come in, let's say, for efficiency and accuracy and speed, but the most fundamental thing, and that also refers to public financial management, but also health financing, is to have adequate health financing policy in place. The health financing policy itself must be able to move towards to contribute to universal health coverage objectives. The digital technology is not going to solve that. So in that sense, for me, it's a basket of factors. It's having good health financing policy in place and good public financial management rules in place. Then the digitalization can actually contribute to that. Maybe I'll stop here. Thank you.
Thank you, Enki. So I'm going to jump into panelists and I'm going to change the order a bit. So apologies for that. Mithul, I'm coming to you first, and that's what I'm looking at you. Because Enki has been talking about platforms, and she has mentioned it a couple of times. And you have been working, Microsoft Consulting has been working on creating the digital platforms, both for public sector as well as private sector. So your experience on how easy is to get those platforms designed, firstly aligned to the need of policymakers, and the data input, right? Again, a good quality stochastic data input. So what has been your experience on this user friendly data which supports both the consumer as well as the payer out here?
Thanks, Malik. So as has been said earlier as well, and I'll repeat it. So technology is part of the solution, but it can bring efficiency, but it can't change practices. And that's what all of us would have learned the hard way. The practices are ingrained, and particularly I'll just want to focus on the public finance management. And I'll stray a bit away from what you asked, because it's just picking up from the earlier presentation. So when you're talking about public finance, there are only two levers there. One is to increase the revenue, which is eventually increasing taxes, which is politically not a great strategy. So politicians would generally oppose the idea of increasing taxes. Then it comes to the other lever is how can you optimize your spending, and and of course the budget. Now, in the current political and geopolitical scenario, it's going to be very, very difficult to increase spending for anything, including health. The large part of increase is going to be for defense. Now, the question is, how do we do more with less, right? And that's where the idea of efficiently spending the budgets come in. Now, we have done a lot of study on the data, including health data. I don't have access to the latest one because the credible data comes after the CAG review happens. So I think I looked at the data, which was a couple of years dated, and if I remember correctly, about 20% or so of health budgets was unspent. Now, at one hand, we say increase, and that's true for most sectors, that we want to increase the health budgets, but we are not even able to spend what's already been allocated. And there are multiple reasons for it. It's not that there's a desire to not spend them. Usually, if we see how spending happens in the government, the money is pushed to the implementing agencies and it's counted as expenditure. So, in fact, money may be parked in the commercial bank accounts of those implementing agencies, but it's counted as spending. And that's when the audit happens and all that. And then you get to know how much money is actually lying in the system. So it creates a unique situation of plenty and scarcity. There are implementing agencies that would have done or spent what they were allocated, and there are others who have sitting on plenty. And the transparency is also not there at times. So the decision makers don't even have complete visibility. Fortunately, with the last 3-4 years of effort, now this problem will reduce to a certain extent because of initiatives like SPERSH and SNA SPERSH, which will improve the visibility of where and how much money is lying. So for that particularly, we have been working on two ideas. And I'm saying ideas because these ideas are a combination of technologies, practices, policies, and in some cases, minor changes in the laws as well. So what we are saying is, first we are saying is just-in-time fund flow. What it means is money should move out of the government treasury only and only when it has to be paid to someone. And in this case, someone is either a service provider or a goods provider or a say a beneficiary or in case of health, a health worker. Whenever money has to be paid, it should move out of treasury. There shouldn't be any intermediate parking of funds. Now, what it means is in theory it looks good, but in practice it's difficult because now there are so many rules and regulation governing these things. There are Government of India's financial rules, which by the way we've also studied, and we see that they enable such kind of things. But the practices that have followed are not conducive to it. So we did some pilots, and one of the states that agreed to do pilot was Odisha on these ideas. So we did these pilots that can we implement a just-in-time fund flow system. So, but what it means is, imagine in very common terms, imagine it like a credit card. When you take a credit card from a bank doesn't give you money upfront. What bank does is, it says that if you present this credit card to any merchant up to a certain limit, that transaction will be done. Similarly, in GIT, every agency will get their get their eligibility for spending or their budget for spending, but no physical money will move into their bank accounts. But there will be guarantee, just like in credit card. If you spend up to this much money, you will get your conditions will be honored. So this is just in time, and that's been implemented in Odisha and a few schemes, and they are expanding it to others as well. The second part, which is more difficult, which we call as smart payments or smart contracts. What it means is, now we have solved for one problem, that money will move out only and only when some act has been completed on the ground. But the challenge is, who will certify the act has been completed? If it has to be done manually, in case of health, if say a health worker on the ground has done inoculation and she's entitled to her money, but that approval process might take few months, few weeks. So then the whole purpose of GIT is defeated. The idea is, how can we make the events which are happening on the ground near real time? How can these be reported near real time? And there are good examples across sectors where it's now happening. For example, in some of the road development projects, now what is happening is, now drones are flying in, they are measuring how much road has been completed, and based on that data, the money or the payment can happen. Similarly, in agriculture, what's happening now is all of us gets agriculture estimates, for example. So government declares this is how much the pulse production or the grain production is going to be. It is based on some estimates. Now, for that estimates, now uh, uh, a worker on the ground has to go to a particular farm, and it is georeference, so there is very less chance of fabricating the data, and that person also has to take the photograph. Now, with photograph and with AI, you can also verify whether the crop is of wheat or rice or something else and what is reported. Similarly, in health, all these things are also possible. So, for example, for nutrition, if you're trying to measure, say, the stunting, wasting, can you take photographs and can you take AI sort of models to do that? And then can you link it with the public finance? So just to summarize, so there are multiple ways to do it, but it's not just about technology. It's also a lot of change in the practices, procedures, and I'm very hopeful with this so much changes in AI and so much of euphoria around AI in India. I think some of these changes will get accelerated.
Yeah. Mithil, I want to talk about a consumer perspective here because you have talked a lot on supply side, right? And it's also important for me, and you touched upon where my money is stuck, right? If let's say if I go to a public health facility and I want access to medicine, they say we don't have money. While, as you rightly narrated, that money is parked somewhere. How consumer can be part of this entire ecosystem, and how this digitalization or data visibility can help consumer? Any thoughts on that?
Yeah. So I think, yeah, again, a very, very good question. So uh, again, I'll start with the positive. The positive thing is with all this social media and so much of transparency that the customers or the users or the citizens are expecting, it is starting to flow into the political system. The politicians want transparency, not just for themselves, but for also for citizens. So I think awareness is increasing. Now the challenge is it's not that governments don't want to be transparent; they want to be transparent. But the problem is the way data is structured. The data is structured in such a manner that it becomes close to impossible. Jokingly, I say if you ask the same question to multiple people in a same department, you'll get different answers, right? And if you ask the same question at a different point in time, you'll again get different answers. It's not that because their view of truth is different. So the idea is to get single source of truth. And again, some sort of the newer technologies, the digital technologies and AI based. I'm particularly stressing on AI because AI is so good in dealing with unstructured data. So now you don't have to worry, and it's little far ahead. We don't have to worry about APIs. All of you would have heard of API, not active pharma ingredients, but application programming interfaces, which in fact connect multiple systems. Earlier, you had to create so many APIs, and that's how the data flow would happen. But with AI, all that would not be required. Of course, there are other changes that would be required in the system, but that could happen. So I'm just building everything on technology because with technology, the data will become accessible. And once data become accessible, there is desire in the government and in the political establishment to expose that data to the citizens. And now it can be exposed in a very, very cost effective manner.
Yeah, thanks for that. Let me go to someone who has been working on data at a government sector, and thank you, Dr. Manish, to be here. I don't know. We a lot of transformative changes are being spearheaded by Niti Aayog. So I know that you are not speaking on behalf of Niti Aayog, but as an individual. But when we measure the development happening at aspirational district level, aspirational block level, right? How do we use these digital technologies to assess the impact, or in other words, that in this resource constrained environment, how do we optimize the use of available resources to see that maximum value has been attained out of the investment?
Okay, thank you, Maulik. What Mithul has said, that he talked about how to do more with less, and he also talked about the plenty and scarcity as well as the transparency. In the today's scenario, what is concerned is the government of India do not have infinite resources. They have like a finite resources, and the day to day, these resources are getting lesser and lesser for the public consumption. So what is the solution for this? How we are going to spend the money that is needed for the society, for the people, for the communities, which are at the margins of the development. So what is suggested here, like when I go to the deliberations with the government and the private parties and the uh, like the community-based organizations, it is not like that a resource should be presented in some way that it has to be smartly prioritized. It has to be prioritized in a such a way that it can create efficiency. And with that, there has to be a accountability also. What I'm suggesting is that in like healthcare, we have a preposition of triaging. When there is a problem of whom to save and uh, whom we should discard, then the concept of three things which is coming up. And in terms of resource utilization is concerned, government of India should try to understand in terms of essential, desirable, and aspirational. What is essential for us? Like when we were small, there was a movie called Roti, Kapda, and Makan. So these things are very, very essential. Then what are the desirable things and what are the aspirational things that we can think and we can work on those lines? Then there is a concept of how that which intervention will create higher impact. That for example, Jal Jeevan Mission and Swachh Bharat Mission, these have created a very good impact on the society. But is this impact has gone to the last member of the society which needs that thing? That has to be validated, and that validation is very, very important. Then I will talk about that how this cost effectiveness has to be made, because government of India always comes up that if we are spending 1 rupee, that how much money in return of investment what we are getting, that has to be very, very important. And then this is a very debatable issue, and people say that convergence will not happen. And but I am very confident that convergence should happen and it must happen. So what is that convergence has to be all about? We have to see that how we are going to pool the resources, how we are going to talk about the inter-ministerial level, and there has to be a kind of a convergence ministry also that will talk about that how this convergence will happen. Because right now we are not talking to one ministry is not talking to the another ministry, and we are working in silos. Uh, in terms of one more thing which I wanted to highlight is the public-private partnership and the role of the CSR, because the funding is getting lesser and lesser. Then the role of the CSR and the private players is there. But the only thing is that we should not think in terms of how to get the money from the CSR, how to get the money from the private players, but how to spend it, where to spend it, and when to spend it. That has to be very properly planned, and that has to be planned with the also with the private players. There has to be a voice of the private players in terms of the money that has been donated by these people. The last is the capacity building, which I will talk about. That capacity building has to be there. To summarize all these things, I can say that government of India should think in terms of spending smarter, not spending lesser or spending more, but spending smarter, so that we are able to achieve kind of like a major impact, an impact in all the states. So in the by our honorable Prime Minister has talked about the Viksit Bharat 2047. So we are able to achieve that Viksit Bharat 2047 by 2047. Thank you.
Uh, Sir, you already touched upon the two important points, right, on capacity building. And you also touched upon uh, data and convergence between various ministry. In this context, how we can, because this is something, it's not new. We know that we need to build capacity of people as far as absorptive capacity is concerned. How can this digitalization or AI help in both the aspects, in capacity building as well as in making sure that there is real-time evidence available for decision making?
Right now, I said that in terms of AI and the impact, what AI Impact Summit has shown, that India needs a long way to go before we can say that India is all AI compatible thing. So the first is the preposition for this AI, that are our ministries, are our people, are our data is AI compatible or not. The compatibility issue has to be there. And this AI compatibility has to be worked on all these points. So I will talk about that. What are the enabling requirements of the AI? How this AI can be enabled? So there has to be a like a interoperability of the digital infrastructure where we can link health, finance, education, climate change, and many more sectors which are there in the sustainable development goals. So that is the first thing. Then the second is that a strong data governance, where I am talking about privacy, security, and standardization. So right now there is a very much issue of privacy, and every day we listen to the different sources that privacy is being infringed, and there is no commitment from the operators about to how to maintain the privacy of the customers. Third is that data analytics and the AI, and in terms of interpretation, all these things needs to be taken into the consideration whenever we are talking about in terms of the AI operability. Like what you have asked about the capacity building. Capacity building has to be there, but right now, if you go to any PHC or a CHC, these people are only being trained because there is a like a quality team is coming up for the inspection. For that number, this capacity building is happening. There has to be a kind of a like an annual plan. In this annual plan, that everybody will be trained, and they will be trained in the area of specialization that they are there for. So what I am suggesting is that we should work in terms of responsive health financing for the capacity building, and for that we can think of data-driven resource allocation. There has to be a granular district level, block level, or the village level data on health, nutrition, and wash. And these has to be taken into the consideration whenever we are planning a district plan or a village development plan or a block development plan. Then this is the most important thing that is coming up and is being proposed by the World Bank, a result-based like a framework. This based framework will provide you an insight that how this funding will be taken into the consideration. Your results or your outcome are going to decide that how much money you will get this year and what will be the contribution in the next year. One more thing which I was evaluating this Jal Jeevan mission and the Swachh Bharat mission. Then I came to know that there is a concept of tied funds and the untied funds. And this is very, very important that untied funds, there has to be they cannot be used for the defined measures that is being there in the gazette. Apart from that, it cannot be used. So there has to be some sort of a leverage from the government that untied funds can be used at the time of the emergency or at the time of some sort of for the community improvement or empowerment that has to be concerned. Lastly, but I can say that real-time monitoring as well as the adaptive financing is the one mantra we can think that how this can be done. And to summarize all these things, I can say that uh, combine data with flexibility and the performance metrics, and that has to be supported by the strong local capacities to drive measurable health outcomes. So this is the mantra we have to work. We have to see that data, flexibility, and the performance needs to be entwined together so good and so smartly that they are able to provide the expected outcome that we are thinking of. Thank you.
Thank you, Manish. Now let me come to Casey, sir. Sir, and all this things that have been shared are very idealistic in nature, right? When we are talking about converging 21 ministries, right? And let's say if I have someone in Janadan or Manrega, now the name has been changed as a beneficiary. There is someone in PMJ who is a beneficiary, right? How can I tie up those people, right? What kind of administrative, technical, and governance capacities are required at state level to make this happen? Because these are this unique identifier needs to be there. We have something in health as ABA, but you worked on Aadhaar, right? And we know the challenges that Aadhaar has been in kind of using as a unique identifier across boards. So what would be your guidance in kind of the capacity that needs to be built at a state level to make these things happen?
Yeah. So thank you, Maulik. And just to add, so whatever perspective I would be bringing in, so I would like to add that I also handle the state finances, specifically in the election year, in which Madhya Pradesh actually changed the whole scenario by introducing direct transfers of funds, which actually is now very popular. So most states have adopted that. So you can blame me if you want for starting that. And but actually, I have a very different opinion about it. And the second issue that I would just like to point out, ki whatever perspective I'll be bringing in, is for the last 4 years, I'm very closely involved in running a 125-bed hospital, which is a family hospital, and trying to transition that into a more professionally run institution. It all came to us because of certain family circumstances, but yes. So whatever learning I have had, so I would like to start off, see, the first thing that we would want in the government, especially, and I would like to pick up from what Inke's presentation said, that see, in the present scenario, we need to design things. Unfortunately, what is happening in the country, and again, I had certain exposures to these things, we actually not designing our policies. That's a very unfortunate part. We pick up whatever we think is the best and then present it as a policy. While having been formally trained in public policy, the first thing as a public policy analyst is that you need to consider different options and different stakeholders so that whatever each stakeholder is asking for needs to be answered in your policy. Whether I am accepting their point of view or whether I'm not accepting their point of view needs to be answered in my policy. I would say that I have been pretty successful in many cases, but yes, overall we need to bring that concept into the government. The next issue is specifically only limiting myself to health sector over here, is that we have seen the transformation of health data in the public sector. So we have actually moved from digitization to digitalization in the last 1 or 2 years only. I would disagree that we started off in 2014. See, because even in Ayushman, etc., the platforms were very weak. And the recent transitions to the NHS TMS portal for both CGHS, Ayushman, etc., is actually making a lot of difference. Even now, not all insurance companies are on digital platforms. Some of them have to be sent, the claims have to be sent by post. So they ask for a courier detail, and then all these things are happening. So anybody who works in the private sector in the health understands this. What I would like to start off with is that most of our, except if we lead what the Niti Aayog has mentioned as the missing middle of around 30 to 40%, depending on what data you look, who are not covered by various health schemes. And all these health schemes are now open to the private sector also. So definitely what we need to look into, the first capacity that the government needs to develop is that we need to have an outlook and an understanding that yes, the private sector is also a part of. So let us say institutions like MicroSave or anybody else, or even your institution who's working in this field in public health, WHO, they are all stakeholders in this business of providing public health to the citizens of this country. So we need to understand that. We need to develop mechanisms which are very transparent. The government is yet to see the capacity that needs to be there. We are still very regulatory in nature in the health sector. So we have one set of laws which regulate people. Even when we are asking people or the residents of this country or the state to go to a private institution, the nature of the government is very much regulatory in nature. They are not looking it as something that they are trying to facilitate through a private institutions. So I think that need, the mindset needs to be changed. What I would also say is that, see, there are different platforms that are available. When you have spoken about a common platform, fortunately, what Madhya Pradesh did was that we built a database, what is known as Samagra. So, matlab, 99% or 95% of the state's population actually has a very unique family code. See, the problem with many kinds of individual identifiers is that they do not link a family together. While my entitlement is based on a family. So if I look at Ayushman, which is one of the largest service providers in the public health sector now, because even, see, most states, what they have done very interestingly is it is not for the private institution only. Even the state institutions, the health centers, the medical colleges have a claim in Ayushman. So even if they treat a Ayushman beneficiary, they get paid for it. So for both ways, actually, it works. And so we need to have a family identifier. And Samagra in Madhya Pradesh actually provides a family identifier, while most Government of India schemes and identifiers are now based on Aadhaar, which perhaps in 2010, when we started off, which is a long way back, we had very different issues on trying to convince people and even convince the unique identification authority on why it should be a family based identifier. And there needs to be a family linkage because most schemes are based on family. So I think we need to have a family kind of an identifier for these things to succeed. One capability that I would also look in the government is actually a lot of understanding about how to process these claims. And so processing these claims also does require, right now what we have again is some algorithm based, some AI based algorithms which actually do screen, but I don't think so they're very effective. And as we saw different things and technologies, which technologies have brought in, drone based, AI based identification. And when we talked about agriculture, Madhya Pradesh is one of those states which has all crop damage estimations based on satellite imagery. And the transition was very simple. One fine day, the state and the political setup decided that we'll move ahead, and they simply moved ahead. And believe me, the politician was the first person who was very happy about it. So moving from a manual crop cutting experiment on moving to a satellite based imagery. So the transition has to be abrupt. It cannot be in phases. There are many things that do not happen in phases. So just to conclude this part, I would say is that when we are talking about the government capabilities, etc., there are different aspects to it, but primarily I would pinpoint the thing that we have to be stop regulators, and we need to look at just facilitators, that even in the health sector we are trying to facilitate things and there are different stakeholders for us. It is not something that we are doing it for ourselves. And जो एक होता है ना माई बाप का कल्चर जो है वो चीज हमें छोड़ना पड़ेगा. See, anybody who has dealt with government reimbursements understands that they still have a very regulatory approach.
Yeah, we have got gentlemen sitting out here who struggles with government reimbursement for a long period of time. But
Yeah.
you also have a very positive story in terms of e-rupee, right? Which has been a kind of move away from a supply side regulation to a demand side kind of, and there was a lot of digitalization used as far as evolving that e-rupee concept and making it a reality. So what is your experience as far as e-rupee is concerned, and how other kind of ecosystems can learn from the experiment of e-rupee?
Yeah.
And something which has not been scaled up, let me put it that way, because it's a
Yeah.
good concept but not scaled up.
Not scaled up, true, definitely. So what I would say here is, see, we in the health sector perhaps, again looking at certain datas, you would say that after the Ayushman, I would even add CGHS, I would even add reimbursement from the state government. Different states have their own schemes. You have railways who are So they're all sending their people not only in their own institutions, they're also sending them out to other institutions, especially in the private sector or even in the government sector. This transformation has also happened across states. So let's say I get a case from Uttar Pradesh. He has an Ayushman card from Uttar Pradesh and he is trying to get himself treated in Madhya Pradesh. So he lands up at my hospital and gets treated, and I get a reimbursement. So what is happening is that reimbursement for individual treatments, especially in the indoor patient, we do not have a system in the country for outdoor, leaving aside CGHS and a few insurance companies. But for the indoor patients, reimbursement is for individuals. And definitely, I think more different kinds of treatments need to be, mechanisms need to be brought in. So e-rupee was a concept which was launched, which NHA flirted with it a little bit. And Madhya Pradesh, we again tried it out for agriculture. For agriculture implements reimbursement. But the basic issue was that as a concept, there are many things that Government of India floats. Let me be very frank over here. But it takes a lot of time and especially a lot of effort to bring it to the ground level. For us, it took nearly 6 months of hard work, working with Pine Labs, working with ICICI Bank, working with NPCI, even getting RBI into the picture, which perhaps I was able to do because I had friends everywhere. So I had personal contacts to get it done, and finally we were able to execute something of an e-rupee mechanism. Government of India also tried it. He was one of my juniors. He also tried it out, but yes, he has also partially succeeded because Ayushman doesn't have a reimbursement for investigations. But what has moved on beyond now is that RBI has brought in that central digital currency, which is of course programmable. So I would say what Mithul was saying, that we need to have smart contracts, something that was a concept of bitcoins, need to be brought into a central programmable digital currency. I understand it's going to be a very difficult work because especially it would need somebody having a domain expertise in government, in schemes, and also technology. So it has to be a combination of that needs to be brought in. Another concept that I would like to highlight here is the outcome-based funding. And again, outcome-based funding was tried out by different agencies in different schemes. TB was one such scheme in the health where outcome-based funding was given through USAID. And but now what happened, again, I'm talking about the delay. In 2019, Government of India announced setting up of a social stock exchange to handle such kind of things. It was in the year 22 when SEBI actually came up with a guideline to how to set up a social stock exchange. And in the outcome-based funding, I think the first scheme that we have got is from Madhya Pradesh again. That was approved in the month of January. And that interestingly is for giving a scholarship for OBC-based students for being trained and sent to Japan. So again, it's an outcome-based funding. So I think there are these methodologies which are available, and these methodologies need to be developed. But I'm sure these are driven by individuals who are working. But let's say the government again, and I would again agree with Dr. Manish is when he said that you actually seriously need a ministry for convergence. But in my opinion, having handled the finance, it is either the finance which has to do it or institutions like Niti Aayog which have to take the lead. And I know that because as finance for health sector also, we were able to do many initiatives. The biggest thing I think that has to happen from the public financing is that the more and more we are shifting, especially towards private sector in health services, in the public health services, these things are now entitlements. And it will be very difficult, as Mithul has mentioned, even in just a time, the states would need to develop a huge treasury kind of a mechanism like banks, just to ensure that whatever payments are triggered at whatever time. How do bank works? Banks simply work because they have a provision that any amount can be withdrawn. And unless there is a huge run on a bank, the bank is able to support that. How do the governments do that? Perhaps that is a job that Niti Aayog will need to do. That you need to have a strong mechanism of treasury in the state governments, where just-in-time mechanisms of RBI Sparsh can operate.
So
That's all. Yeah.
I think so. We are lucky to have Alok Ranjan. I think so. We go to 15 minutes, but you joined right on time. And so this is something that Alok can respond to it, because Alok is kind of a senior program officer at Gates Foundation, looking at public financing and digitalization a lot. So Alok, your experience, and you're working in a couple of eastern states. So your experience, that when you make investments in this digital public finance, what is the impact that you have seen over a period of time? And I'll put both the questions together, because this is what you have done at a country level, and I think so foundation is also going beyond India to see that how other ecosystems globally could be evolved. So Alok, your reflection on that, and what the colleagues have been talking is, as you heard KC sir on saying that a state can act as a financing institute, and Mithul talked about a smart contract, and Manish did talk about the role Niti Aayog can play in kind of making sure that there are enough kind of monitoring datas and structures for convergence important for this thing to happen. So I'm just briefing what these colleagues also spoke about. Alok, thank you for joining first.
Thank you, Maulik, and my sincere apologies for joining late. I had to be a part of a government committee meeting. I think one of the things I picked up Kesri sir talking about, which I think lies at the heart of this, is convergence. So I think over the last 20, 25 years, we've seen a wave of digital systems coming in place. But in many ways, many of those digital systems have replicated the silos that existed before those systems came in. I think convergence, there are different elements to this convergence, but at the heart of it lies the language or the shared digital data standards that can allow two systems to talk to each other. Right? We have these digital systems, and for example, there is a PFMS system that can tell you what was sent out and what was spent at a spending unit level. There are health information management systems that can tell you service delivery information. There are claims management systems that can tell you the claims that were paid out. But the ability of these systems to talk to each other is very limited because the shared common language for that does not exist. I think in defining that shared common language, as Sir said, there is a Ministry of Finance or a Niti Aayog equivalent that can probably take the plunge there. But also potentially an organization like MOSPI can set out those data standards. I think once systems have the ability to talk to each other, a critical bottleneck in government gets resolved, which is connecting the physical and the financial. I think that's at the heart of everything PFM. We have physical information on physical progress in different systems, on financial progress in different systems. The ability of the state and the public officials to connect the physical truth to the financial truth remains limited because of various reasons and poor administrative data quality. And that manifests in a lot of ways that we see as external actors, as sort of delayed payments, money not reaching a hospital on time, et cetera, et cetera. So firstly, defining that common language is very important. More practically, I think, we have made progress, or we are in the process of making progress on that in India. Three critical elements, I would say, that are important to get that language right is shared identifiers. This could be ABA IDs, this could be registries for providers of facilities so that things like services, claims, payments can be tied to the same entities. The next is the data standard itself that allows systems to talk to each other seamlessly, and a data exchange layers that systems can, through which systems can interact with the system of APIs instead of doing one-on-one integrations, which are time-consuming, expensive to do, but also fail once the system itself evolves. The other part to say is that convergence or interoperability between data systems is often talked about as a technical aspiration, but it is as much a policy and a governance question. So one part of this puzzle is to define those data standards, but then it is to set the right incentive compatible mechanisms in place that allow for actors at different levels, whether that is within government or outside government, to adopt those data standards, which is when truly this integration happens. When we talk about government systems itself, I think the open question remains of how you can integrate this into procurement systems of government, right? So rather than standardizing or rather than centralizing, you're defining a data standard, and then it doesn't really matter who builds that system as long as it speaks to a particular standard. Over and above that, I think maybe a third aspect to say is that ultimately this comes down to adoption. Ultimately, it comes down to incentive compatibility. Even when we talk about digital systems, what were supposed to make let's say frontline workers' lives easy have in many ways complicated their lives. There's sort of duplicate data entry, multiple systems to respond to. So unless we set the right kind of incentives for both public officials and private sector actors to use this, which will come from reducing their own administrative burden in engaging with these systems, we won't see that ground level adoption happening. So maybe I'll stop here for any follow-up questions.
So let's say if I'm a state in India or a country who's going to start on his digital journey, right? Where should the investment start from? Should it be investment in creating those architectures, or it should be investment in creating data sets? Where should how does the investment prioritization should happen as well as creating digital ecosystem is concerned?
Yeah, maybe two critical parts to this, right? One is, more broadly speaking, I think the government should focus on building the shared rails, very much like what we are seeing in the broader India stack. What are those digital public rails for the health system actors to jointly collaborate on building this digital ecosystem? Those shared rails can be, as you see in ABDM, they can be registries that are, make identification easier. They can be health information exchange systems, individual identifiers like an Aadhaar ID, etc. But the second part of the problem is also to ensure that private actors have the right kind of incentives to build on these shared rails, right? And that really comes down to having an open ecosystem that is made available to all these actors. Over time, this ecosystem should allow multiple actors to build on it. Providers should be able to plug into the same system, and purchasers should be able to then use this data to make better purchasing decisions in the future. So as long as it is that standards-based approach that allows you to use these shared digital rails to build your own products, but products that speak to the same language, that is sort of the way to scale. In public finance systems, I think one important thing to remember is that integration very often does not scale, but interoperability does, right? So the entire banking ecosystem that has been brought together by UPI could have been multiple one-to-one integrations, but there's a reason they don't happen because they're costly and expensive. But something that is a shared sort of data standard like a UPI can then enable actors to scale much faster than a one-to-one integration.
Thank you very much indeed, Alok. I think so. Thanks for coming in a nick of time to get this insights. I know that the panel is standing between you and lunch. So any closing remarks? And I'll go to Enke first. Enke, are you there?
Yes, I'm here. Hi.
So thank you very much for being with us and listening to all these experts. So you heard 4 experts, right? Based on your global experience, if you want to say that this is something that India should be doing based on your ecosystem, right? What would be 1 or 2 takeaways that we can have?
Okay. Yes, thanks. That's a super important question. And yes, having listened to now the 4 speakers and panelists from India, and from the work that I've been doing in on India, for example, we looked at the online referral system in Karnataka, and some other work that I've been doing with the WHO country office in India. And I think it has been said here. So for me, and what I'm observing from outside on India, I'm not based there, is this interoperability issue. I mean, this huge, how can I call it, evolution of different systems which are fragmented, which don't talk to each other, which are not integrated in the first place, but also not interoperable. So focusing on interoperability as part of building up and further developing and strengthening a digital public infrastructure. I think that's from my take, from what I observe outside, that's sort of the key message. The second one is, and it comes back to digital public infrastructure. So one thing is about data interoperability, data governance, but the other one is sort of more of, or equally focusing on the architecture of this digital public infrastructure. How do the systems of digital identifiers, digital payment systems, and digital data exchange system, how do they actually link to each other, conceptually speaking, from an architectural point of view? How do they come together to ensure that actually you can really scale up and get the efficiency gains that you can then get from the system, which will be much larger than just sort of individual effects from each of these systems. So yeah, these are the two key points that I would suggest to focus on. Thank you.
Thank you very much, Anke. I think so. I'll make a closing point on that. I think so. Listening to what Anke said and what your colleagues have said, I think so. Design and architecture wise, I think so. ABDM, who is trying to deconstruct our health ecosystem, is, I think so, is on the right trajectory with 3 interfaces. Creating registries and consent manager, having claims exchanges for faster processing, and having a user interface for discovery. I think so that goes in the right direction. But as most of the colleagues have said, I think so. It's a design stage, and much needs to be achieved for it that this design to be in a reality. And it would require capacity building at various levels, both public sector and private sector, and also certain changes in the way the contracts have been drafted for a better participation of private sector, and real-time monitoring by using artificial intelligence and making sure that whatever input that we are getting are helping in processing data faster to make decision faster, which can lead to better use of financing which is available to us, and enhancing the overall financing goal of efficiency, which can lead into equity. So thank you very much, colleagues. Sir wants to say something.
See, when we are talking about systems over here, just what I would like to suggest is, see, when we use the word architecture of the system, it actually takes us more towards the
Tech part.
tech part. So what I would suggest, and what is being used otherwise, is that we should actually trying to go in for a system design, especially if you consider what is evolving in the Western world is about the human factors design. Is that would bring us an overall encompassing design, which would also design the system, which also design the workflow for the government. It will bring in various concepts. Matlab, that is all that I would like to point out with my experience.
Yeah. Thank you, sir.
That makes a difference.
Thank you, sir. Manish, Mithul, Alok, any closing remarks?
Maybe just one from me. I think zooming back into the public finance sphere, I think the holy grail in public finance is being able to connect budgets to fund flows, to service delivery, to outputs and outcomes. And I think that is where interoperability becomes very important. At the heart of that is a shared common language, data standards, whether that is for the physical part or the financial.
Thank you. Manish and then Mithul.
Most important thing about any architecture or anything that is we are doing in terms of the health financing is the person for whom we are planning for. So the human touch, which is missing from our architecture, the kind of the problems of that person who is having to use that platform, what kind of infrastructure we are creating, that has to be created in such a way that is easy to use. Right now, what is happening is that the infrastructure, whatever the architecture, the design that we are using, is not very simple. So we have to think in terms of simplifying the design, and that design will create a kind of like a usability approaches to the community and the people. And for that, I think that we have to go a long mile. to understand that how this human touch should be incorporated and how to be incorporated into our health architecture.
Thank you, Dr. Manish. Mithul?
So we are living in a very interesting time in India. Many people in the room have seen it all, from liberalization and what the benefit it has had to again closing down of economy. We have seen COVID and now the AI wave that we are seeing. Particularly for AI, I feel it's the most transformative change that's happening in all our lifetime. And it's going to redefine the way we live, we engage, and we work. Particularly for health, I think it can have different manifestations. It can manifest in multiple ways. Few of those could be it can provide personalized treatment protocols for individuals, which are very expensive right now if you want to do that. It will reduce cost. So when it reduces cost, of course, it will reduce cost, but it will not reduce the burden on the exchequer. Why I'm saying so is because if it reduces cost, it also expands the access and it also introduces newer kind of agents. So overall cost of the exchequer might not reduce, but the cost of individual treatments might reduce. And we might be living in a situation where we would start paying for health outcomes instead of health services. It's very extreme situation, but I think the kind of things AI is promising, all these things might be possible. However, it's a big however. All this would need data because data is the fuel for AI. And for data, we need governance. We're talking about sensitive health data. We can't be exposing all of that. And unfortunately, the lot of discourse over the last many years had been on DPI, but people miss the data layer. Who will do the drudgery of building those registries, building those data standards and so on? People was trying to build a layer on top of it, learning from what India did. India started in the 80s, digitization exercises, and all that came together as DPI. And now AI, again, the same mistake is getting repeated, particularly in the global south. But overall, I'm very optimistic.
Thank you very much, Mithil. Thank you very much, panelists, for being here. It has been fantastic conversation, but I am still optimistic because I think so with what ICMR and Dr. Mona Duggal mentioned in the morning, I think so we are going towards data sets. What NH is trying to do is creating anonymized data pools and what Sudha mentioned in the way a couple of states have moved towards DRGs kind of stuff. I think so trajectory wise, we are in the right direction. And I think so with all our partners together, I think so we need to gather steam so that we achieve something much faster and using a political word, maybe Viksit Bharat 2047. Thank you.